Hello everyone, I am Dr. Mahalakshmi. In this video, we are going to see regional injury. So, regional injury, here we will be seeing the injuries that will happen to the central nervous system and cardiovascular system. Mainly these two injuries we will be seeing here. These comprises the most fatal injuries and most common injury that we will be seeing in our day-to-day practice. So, these injury, especially CNS injury, brain and spinal cord, that is what we are mainly going to deal with in this chapter. Apart from that, we will also be seeing traffic injuries. The injury that happens during road traffic accident, like automobile accident, some accident, like what will happen during that accident, all the injuries we will be seeing in this chapter. And in this chapter, first we are starting with the head injury. So, in head injury, we will be seeing these things. So, first you are starting with the scalp, then you have the skull, then you have the brain. So, all these things we will be seeing here. So, initially this scalp injury, skull injury and brain injury, most of the time when they come to the hospital, what you have to mainly remember is that like up to 24 hours, they should be monitored. Like you may think that it is a simple scalp injury, simply some swelling is there in the scalp, nothing else is there, there was no loss of consciousness, nothing is there. So, it is something very simple, we can send the patient like that. You should never send them, because these head injuries, even it may not have anything exterior, but still there may be chance for concussion or diffuse axonal injury inside. So, any patient coming with a head injury, you have to hospitalize them for 24 hours and you have to monitor them completely. If possible, do a NCCT, non-contrast CT brain, to rule out any acute hemorrhages in the brain. So, this is the main important thing that we have to know. Like starting with this chapter, that thing that we need to know first is this. Like whether they have scalp injury, skull injury, anything, you have to monitor them for 24 hours even though they look normal. So, this is the initial thing we are starting with. Now, this head injury, how they are getting the head injury? It can be divided into either primary head injury and secondary head injury. So, primary head injury means because of some trauma. Like it can be blunt or penetrative. Any trauma that can result in the injury. So, it can be a fracture or it can be hemorrhage, something will happen, some trauma will happen and they will get this contusion, hemorrhage, or something will happen in the head. So, this is primary head injury. Now, we are going to see secondary head injury. So, secondary head injury means because of this primary head injury, let's say a patient, he is suffering from subdural hemorrhage. So, slowly he is getting lot of hemorrhages and a big mass will happen, or EDH, very big amount of blood is getting concentrated in the area. Now, what will happen? This will act like a space occupying lesion, right? So, it will act like a space occupying lesion, and because of that, the patient, there will be cerebral edema, there can be herniation, or due to repetitive stress or something, there can be sometimes contusion also. So, because of the primary injury, because of that initial assault, there will be something happening. Because of the initial assault, something else will be happening, some pathology will be happening in the brain tissue. Those injury we call them as secondary head injury, because they come secondary to the primary initiating factor. So, this is the secondary injury. Primary injury, you have a direct trauma that will result in any fracture or hemorrhage or contusion or necrosis. Secondary head injury, because of that fracture or hemorrhage, you will get some pathology developed inside your brain. There may be some electrolyte imbalance happening, or there may be some space occupying lesion like happening, like herniation, edema, all those things may happen. So, all these things, it will come under this secondary head injury. So, this is the basic classification of the head injury. Now, we will start with the scalp. So, scalp, the most common injury you will be seeing is a bruise and laceration. And scalp, it consists of all this layer, right? So, you have the skin, connective tissue, aponeurosis, loose areolar tissue, and the periosteum. So this consists of the scalp, right? So now in the scalp, in any of this layer there may be an injury and there can be bruise or laceration. Now the bruises are better felt than seen. Because of the hair and all, it is always better to feel for the bruises. You will not be able to see the bruises, but if you palpate, you will be able to see the swelling. So bruises in the scalp are always best felt than seen. So this is the main thing about the laceration and bruise in the scalp. And any bruise, any hematoma that happens in this fourth layer is this known as very dangerous area. Why? Because any hematoma here, it will communicate and it can become intracranial. So any infection that goes to this hematoma, it can extend intracranially. So intracranial infection can happen from this layer hematoma. So this is very dangerous layer, and bruise and laceration are very common in the scalp. Next thing that we can see in scalp is avulsion. So this avulsion, it is commonly seen when there is any machinery. Like I saw a case, what happened was that they were using this grind machine, like where they will put the grind and it will just cut down all the parts and will give us the grind. Okay, that machine they were using, and unfortunately that lady's hair, it got inside that machine. So that machine, it pulled her hair, along with it her scalp got avulsed. So the top of the head, the scalp, it will come. Okay, your scalp, like a cap, your scalp will avulse and the cranium will become visible. This avulsion is most common in these machinery injuries, and if there is any accident, if there is any running over, if the head is getting inside the machinery or something, like under the tire or anything, that time also there can be avulsion of the scalp, leaving only the skull. So this avulsion is also seen in scalp. Then whenever you see a injury in the skull, be it a bruise or laceration or avulsion, what you have to do is you have to do hair preservation. So why? Because when we analyze the hair, we can say whether it is cut or crushed. When you look it under the microscopy, you will be able to identify whether the hair has been sharply cut or it has been crushed. So depending upon that, we can say whether it was a blunt force trauma or a sharp force trauma. This will become useful when you find an unknown body with a head injury. So there may be some laceration over the scalp, and you can see inside there is a big fracture in the skull. So now you won't know the exact history. So whether this happened because of some accidental fall or something, or if someone did something suspicious like homicide or something, that you won't be able to identify from the history. So in that case, what you can do is you can take the hair from the site of injury, and if you look it under the microscope, the tip of the hair where it was cut, you will be able to see whether it has crushed or it was cut. So that thing will help us to identify whether it was a sharp trauma or a blunt trauma. If it is a sharp trauma, then most probably something suspicious might have happened. Blunt trauma, mostly accidental. Sometimes someone might have used some blunt force weapon also. So like that, we can get an idea by doing this hair preservation. So this is the basic thing we have to know in the scalp injury. Next, what we are going to see is skull fracture. So skull fracture, it may happen due to direct violence or indirect violence, and it can be a general deformation or local deformation. So these are the two categories in which we will be seeing the skull fracture. What we mean by direct violence is that there will be trauma, direct hit. There will be direct trauma or hit directly to the head. Because of that, there will be skull fracture. Indirect violence is this commonly seen in fall from height. When they land on feet, what happened? That force will be transmitted through the feet spine to the base of the skull. there you can see base of the skull fracture, but that fracture did not happen because of direct violence. It was mostly a transmitted force from the feet. So directly some weapon is getting hit and you are getting skull fracture, it is direct violence. And if it is getting transmitted to some other body, like in case of solid explosion, you are standing over a deck and there is some underwater explosion happening. So what will happen in that situation? The blast wave will travel through the ship, the floor of the ship, and it will transmit through your feet, spine and to your skull. So in this case, you will get injury or fracture over the base of the skull, which happen indirectly. So this is the indirect mode of skull fracture. Now, you can get either general deformation or local deformation. So what we mean by this is that local deformation is like you will get a weapon, the small strike area, so like a hammer or something. So a weapon with a small striking area, so you will be like putting the weapon over the head and there will be local deformation. Only where the contact was made with the weapon, there you will be seeing that injury. All other places it will be free of the fracture. Now general deformation is like all over the skull there was force. This is commonly seen in accidents when their head gets under the wheel, like overall all over the skull there will be impact, right? So your whole skull will get fractured. So this is general deformation against the local deformation, where you will get a weapon with a small striking force attacking the skull. So this is the basic classification of the skull fracture. It can be either direct or indirect or general or local. Now we will look at the each and every type of fracture which is commonly seen. So first we are going to see depressed fracture. So this depressed fracture here, do you see this? This is your depression. It will look like a depression here. See, this is your depressed fracture. Now, if you can see, this is local deformity or general deformity. This is local deformity, right? So this is a very local deformity, and usually the weapon that could have caused the skull fracture would be a weapon with small striking area, mostly something like a hammer. So this could have caused that. And what happens is that when this strikes, there will be depression. The inner table and outer table both will collapse. Okay, both tables will collapse and the bony pieces, it will driven through the brain. So the piece of the skull, it will go and impinge over the brain. So because of that, you will get severe injury to the brain structure and there will be multiple pathology in the brain activities. So this is the importance of this. Both the tables will be deformed and there will be depression, and the skull fracture, that fractured part, it will go and hit the brain, causing injury to the brain tissue. And the other name for this depressed fracture is fracture a la signature. Why is that? Is like this fracture, you can see the weapon's image. Like this must have been the striking surface of that weapon. So this must have been the, like a hammer must have hit with the surface like this. This must have been the striking surface of that weapon like that. That weapon is leaving a signature over the skull, and using that you will be able to identify the weapon that could have caused this fracture. So that is why we call it as fracture a la signature or signature fracture. So this is the important thing about this depressed fracture, and the medico-legal importance is that it can lead to severe brain injury. Brain damage can be severe, and like it can help in weapon identification. So this is the medico-legal importance of this depressed fracture. So depressed fracture, you have a weapon with a small striking surface hitting over the skull, pushing both the table, inner and outer table, inside the vault, and that pieces of the skull, it will go hit the brain, causing injury to the brain tissue, which can lead to severe deformity. And that striking surface will leave a mirror image in the skull, which we call it as signature fracture. And medical legal importance is that you will be able to identify the weapon that caused the skull fracture. So this is the thing about depressed fracture. Clear? Next we are going to see Pons fracture. So Pons fracture, what will happen is that here this is the Pons fracture. This is also known as ping pong fracture or indented fracture. This is actually a dent. This is not a fracture itself, it is actually a small dent. So what will happen is that this is most commonly seen in infants, where the skull is more flexible. So because of the flexibility of the skull will indent and it will not break away, it will not fracture, it will simply, there will be a dent. So this is why it is known as ping pong, like a ping pong ball, it will just dent and it will stay like this, and there will not be any brain injury. There will not be any brain injury, and it is mostly seen in infants only because they have these malleable and flexible skull, and it is most commonly caused during delivery because of usage of obstetric forceps. Otherwise, you can also have the fall of baby. Because of the fall, like that hit to the head, it can cause this indented fracture. So this is about the Pons fracture. So it is basically a dent, not an exact fracture, commonly seen only in infants, and there will be no associated brain damage, so there will not be any deformity or anything seen in the baby. So these are the first two types of fracture. Next what we are going to see is ring fracture. So ring fracture, what will happen is that it is basically a base of skull fracture. It is a base of skull fracture. Here, this is the foramen magnum, right? So if you see a fracture line along this foramen magnum, it is known as ring fracture. So you will basically see a ring shaped fracture around foramen magnum. So this is the ring fracture, also known as base of skull fracture, and it is most commonly seen in a transmitted injury, like when you fall from height. When there is transmission, a transmission of force, you will be getting that injury. There is a solid blast. When there is transmission of the blast wave through the heel, you will get the injury in the ring. For around the foramen magnum, you will be getting this. So this is why it is known as ring fracture, and it is commonly associated with fall from height. And what is the associated injury you can see is that there can be severe damage. Since it is a base of skull fracture, you can see like posterior cranial fossa fracture, lot of fracture will be seen along with this, and there will be severe brain damage. So this is about the ring fracture. Next what we have is hinge fracture. It is also known as motorcyclist fracture. So here what will happen is that this is also a base of skull fracture, and here what you can see is you have the transverse fracture, like the fracture line. The fracture line will split the skull into two. It usually crosses the sella turcica. So it will traverse across the sella turcica. It will start in one temporal region. It will cross the sella turcica, like damaging the pituitary. Then it will go reach the other end, other temporal end. It will go and reach. So it is a transverse fracture starting from one temporal to the another temporal across the sella turcica in the midline. So essentially it splits the skull into two parts, anterior part and posterior part. So all over the base of the skull, all the fossas, there will be severe damage, and this is commonly seen in road traffic accidents. When the people who are driving the motorcycle, they get hit, you will be seeing this hinge fracture. So these two are basal skull fracture. One is ring fracture, another is hinge fracture. Ring, it will be seen around the foramen magnum. Hinge fracture, it is seen as a horizontal fracture traversing from temporal to another temporal across the sella turcica. And this hinge is seen in motorcyclists, and that ring is seen in fall from height. So this is the difference between this ring fracture and hinge fracture. So next what we are seeing is fissure fracture. So this fissure fracture is also known as a linear fracture, and what it will do is that it will involve both tables. So both table can be involved, and you will be seeing a linear fissure, like a groove kind of thing you will be seeing. And this is the most common type of fracture that we encounter. Most of the cases you will be seeing this fissure fracture, and sometimes this fissure fracture will become a comminuted fracture. This can become a comminuted fracture. When there is multiple lines, there are multiple lines going across, it will become a comminuted fracture. And this deformation, this mainly occurs because of general deformation. Because of general deformation, you will be getting this fissure fracture or linear fracture. And weapon that usually causes this is large striking surface. A weapon with large striking surface will lead to this fissure fracture and comminuted fracture. And the associated fracture that you can see with this is the comminuted fracture. Along with this, you will be seeing the comminuted fracture. So linear fracture, if only one is present, we will say it is a fissure fracture. If multiple fissure fracture come together, we call it a comminuted fracture. And this is mostly seen in a general violence or a weapon with a large striking area. And it will have severe brain damage. There will be severe brain damage. So this is about the fissure fracture. Now the next fracture is diastatic fracture. So this is your diastatic fracture. What you can see here is that there will be separation of suture. So separation of suture will be there, and this is mostly seen in young people where suture is not completed, that fusion is not completed, when the suture is still open. In those cases, you will be seeing this. Because of the general violence, what will happen is that along the suture lines, the bone will separate. And the most common suture that it can be seen is against the sagittal suture. It is most commonly seen in the sagittal suture, and it is commonly due to trauma. Because of some trauma, you will be getting this diastatic fracture. Clear? And next is gutter fracture. Gutter fracture is when the trauma comes tangentially. Like when there is tangential trauma, what will happen is that there may be just scraping away, like this outer table. Only outer table may be scraped. So that fracture, we will call it as gutter fracture. It will go like a gutter. It will form kind of groove-like structure. So tangentially, it will take away, it will chip off the skull bone and it will go away. There may not be any damage to the inner table and the brain. In some cases, there may be damage to both, like both the outer table and inner table, and even the brain tissue will be damaged. So it will form a complete groove. All structures will be affected. All the structures will be affected. So such cases we call keyhole fracture. So all the cases will be affected and we call it as keyhole fracture, and this is most commonly seen with gunshot injury. Gunshot injury is the most common reason for this gutter fracture, and penetrating fracture can happen if there is any sharp pointed object. So it will simply penetrate and it may sometimes perforate out also. If there is a pointed object, something like an ice pick or something, or like an arrow or something is coming at a very greater force and hitting the skull, it may penetrate into the table and brain. Sometimes it will perforate out also. That is also, it is a part of gutter fracture. So these are the most commonest type of fracture that we usually encounter. And most important among this is the depressed fracture. This depressed fracture is very important, and this motorcyclist fracture, also known as hinge fracture. These are very, very important. They will simply ask you write down all the types of skull fracture and what are the mechanism through which fracture can occur, like direct violence, local deformation, like that. You can first classify, then you can write the types of the fracture. So this can be asked as a 5-mark question. So next to the skull, what happens is that you will be getting facial bone fracture. So facial bones, you have totally 14 bones, and all the bones it can get fractured because of the trauma, because of the direct trauma to the face or any accident. It can get fractured, and the classification is known as Lefort's classification. So Lefort's classification, you have basically 3 classifications. So first is Lefort 1 is a horizontal fracture. It will go above the teeth, immediately above the teeth, horizontally above the teeth, below the nasal bone you will see the fracture. So above the teeth, below the nose. Pyramidal, what will happen is that it is also known as it will go from maxilla and over the nasal bone, like a pyramid, like a structure. It will go like this, above the nasal bone it will go. And this traverse or Lefort type 3 is, it is intraorbital fracture, like it will cross the orbit, both the orbits are crossed. So these are the 3 types of facial bone fracture you can get, and it is divided into 3 by Lefort classification. Lefort 1 is horizontal, you will be seeing immediately above the teeth. 2 is pyramidal, where it will go above the nasal bones, and 3 across the orbital bones you will be seeing. So this is the facial fracture. So next to that, what will happen is that you will get the brain injury. So what will happen? It can be either a penetrative trauma. There will be direct injury to brain tissue. All the way it will enter from outside skull, brain, it will go and penetrate the brain tissue, leading to necrosis or contusion or hemorrhage. This can happen. But most commonly what we encounter is this blunt trauma. So there will be blunt trauma. There will not be any sharp force, there will simply a blunt force trauma, and because of the blunt force trauma, you will be getting coup and contracoup contusion. So this is what you basically get with blunt force trauma. So this is how it happens. What happens is that, like, this is the state of rest. Now the body, there will be a blunt force trauma acting, like something will push the body down. So what will happen? The body will start going down. So there will be sudden movement. Okay, there will be sudden acceleration and deceleration because of the sudden movement. What will happen is that here you have the CSF, and this is CSF, you have the skull. This is the CSF. What will happen? Because of the sudden movement, since fluid is like it was more prone to the gravity, it will go towards the gravity. The CSF will go towards the posterior aspect. So all the CSF from the front, it will go to the back. So CSF goes to the back. Since they are falling towards the gravity, all the CSF from there, it will go to the back. And when they hit the ground, the skull fracture or the impact will be over here. You have the posterior aspect getting hit. This is the point of impact. But what will happen? Here the brain will not impact because it is cushioned by CSF. Posterior, there will be cushioning of the CSF. But brain, it will go hit anteriorly because fluid will travel easily, but brain will take some time to travel. So because of that, anteriorly you will not have any CSF and the brain will hit the anterior part. Hit anteriorly and you will get contusion over here. So this is the Contracoup contusion. So the brain will start moving along with the skull, brain, CSF, everything will start moving, but fluid will travel faster and go posteriorly, and posterior impact the brain is cushioned, but anteriorly because of that reverbing, because of that recoiling, that anterior impact will not be cushioned by the CSF, which will lead to contusion in the opposite direction of the impact. So the point of impact is here, but the contusion will be seen over here. So this is Contracoup contusion. Basically what happens is that your body, it will be in a state of resting. So everything will be normal. You have CSF completely cushioning your brain from the skull. Now because of the sudden movement, there will be sudden acceleration. So your body will accelerate and it will start going down. So it will accelerate and it will go down. So when it goes down, the CSF will travel much faster than the brain. So the liquid will travel faster than the solid brain. So this CSF, it will go to the posterior aspect, and when the body hits the ground, when it hits the ground, there will be deceleration, sudden deceleration. So it will hit the ground, but when it hits, because of the CSF cushioning the posterior aspect, the posterior aspect of the brain will not be affected. But this sudden deceleration will push the brain a bit more towards the anterior aspect, and anteriorly there will not be any CSF, right? So because of absence of CSF and this sudden deceleration, brain will go hit against the skull and you will get contusion over the anterior aspect. That is why it is known as Contracoup contusion. The impact is at one point and opposite to that point you are getting that contusion. That is why it is known as Contracoup contusion. So this is one blend trauma related brain injury. Next is Coup contusion. What will happen is that, like, the point of impact will be same as your contusion. When the head is resting, you will have an impact over the head and skull will fracture over there, and underneath the fracture you will get the contusion. So this is Coup contusion. And Contracoup contusion, like we saw, the primary impact will be over here, but contusion will be seen opposite to the place of impact. Contusion opposite to point of impact. This is Coup and Contracoup contusion, and this is commonly seen in temporal and frontal lobes. It is never seen in occiput. Because of the thickness of the occiput bone, you will never see the Contracoup contusion in the occiput. It mostly seen in the temporal and the frontal lobe of the brain. And the theory is that mainly this, because of the sudden acceleration and deceleration. Because of this, you will be getting the injury opposite to the point of impact. So this is your first. In blend trauma, you will get Coup injury, that is at the point of impact, or Contracoup injury opposite to the point of impact. So this is first thing. Otherwise, you will get fracture contusion. Because of the skull fracture, there will be impinging of that bony structure into the brain tissue. So at that space you will be getting contusion, that is fracture contusion. Along with the fracture, you will see contusion. So this is fracture contusion. Next is gliding contusion. This is the most common cause for diffuse axonal injury. Like there will be an angular motion. because of the angular motion, there will be shearing of the axons and you will get this gliding contusion which will lead to diffuse axonal injury. So what will happen is that when there is a angular motion, sudden angular motion, whatever the junction that is present, like gray matter, white matter junction that is present inside the tissue, there will be a shearing force. So it will glide over each other and there will be some sort of disruption in the activity of the cells. So that is known as gliding contusion. And next what you have is herniation contusion. So because of herniation, there will be some contusion, like the area that got herniated, the part that got herniated will get injured, like it will go impinge over the against some fixed structure, it will go and get injured. So this is herniation contusion. So these are the most commonest blend trauma contusion that we usually see in the brain. And this coup and contracoup contusion, this is always seen in the crest of the gyri. So in the crest of the gyri, you will be seeing this contusion, like you will have the brain like, so this is your crest and this is your sulci. So this is the gyri and this is your sulci. You have the gyri, sulci, like that the brain will be there, right? So in the crest of the gyri, you will be seeing this contusion like this over here. So you will be seeing the contusion only over the crest of the gyri. And these contused area, it can tear or there can be hemorrhage or they can become necrose. So all these are sequelae of this contusion. So this contusion, when it keeps on happening chronically, you will be seeing necrosis or hemorrhage or tears. The brain tissue will undergo all these changes. So this is the main brain injury that you will be seeing in the trauma. So next to that is classification. So this traumatic brain injury, how we are classifying? So based upon the Glasgow Coma Scale and consciousness, whether there was any loss of consciousness or not, or presence of amnesia there or not. So based upon these three things, we classify this traumatic brain injury into mild, moderate and severe. So mild, there can be simply concussion will come and they will be all right. Moderate, there can be few deformities. And severe, it will result in diffuse axonal injury. So all these are the grading of this traumatic brain injury. Starting from concussion to diffuse axonal injury, you can get anything. And it is graded based upon the Glasgow Coma Scale score, consciousness, whether it is lost or there or not, amnesia present there or not. Depending upon all these, it will be seen in this thing. So this is the traumatic brain injury, and grossly, this is how the brain structure will be seen. So this is the contused area. So this is the contused area and you can see multiple hemorrhage over here, and this will undergo necrosis, and this as you can see it as shriveled. So this area will go necrosis. So this is the cerebral contusion, how it usually looks like. So you can see it is mostly seen in the gyri. In the crest of the gyri, you will be seeing this, not in the sulci, only in the gyri you will be witnessing this contusions. Now, the medico-legal importance of this concussion is that, like medico-legally, when a patient with head injury, they come to you, what you have to do is you have to observe them for 24 hours. If you let them go before monitoring them for 24 hours, what can happen is that they may be in this lucid interval. So they may be in this lucid interval period. And you may miss the patient, like they may be normal. And before that they might have had some unconsciousness, now they may be normal and again they may worsen. So in that lucid interval, you might have seen the patient and you might have let them go. And if they go to home and they get something like very serious complication or they die, then you will be called for negligence. So people will put negligence case against you. So this is the medico-legal importance of this concussion. You have to monitor them. When they give a history of concussion, you have to monitor them for the period of 24 hours. But if you don't get the history of concussion or head injury, what will happen is that, like, these concussed people, they'll be kind of disoriented and they can be mistaken for drunkenness. Like sometimes there will be amnesia also. So they will be traveling and they will get into some sort of accident and head injury. There may not be anything major seen outside. They won't have any external injury, but they would have had some loss of consciousness and amnesia. So they will come to you and people will think that they have drunken. Because of that, they are disoriented like that. So like that, people will mistake concussion for drunkenness. Without proper history and idea, you won't be able to differentiate a concussion from the drunkenness. So this is the main thing, main medico-legal important thing in this concussion. And the severe form, the diffuse axonal injury, what happens is that organically or physically, it will be looking normal. You won't be finding anything physically, but if you look under microscopy, you can be seeing this retraction ball, also known as beads on string appearance. So this is the retraction ball. So what happened because of this diffuse axonal injury, because of this gliding contusion, this axon will cut and they will become retracted. So what they say is this there will be a axolemma damage. Axolemma is the membrane over axon. So membrane over axon, and this will be damaged because of that diffuse axonal injury. There will be damage to the axolemma and this keep on accumulating, finally disrupting the axon flow, and finally the axon will retract and lose function. So this is what happens. So biochemical theory for diffuse axonal injury is that what will happen is that this commonly occurs in the white and grey matter junction. In the white and grey matter junction, what will happen is that there will be this shearing force acting, and because of the shearing force, there will be damage to the axolemma, that is the membrane over the axon. It will get damaged, and because of this membranal damage, there will be disruption to the activity of the axon. So what exactly happens here is that when this axolemma get damaged, there will be opening. There will be opening up of sodium and potassium channels. So there will be influx of sodium and potassium channels, ions inside the axon, which will disrupt the cellular integrity. Because of that, the cell will undergo lysis and the axon will completely disrupt. So this is the diffuse axonal injury and how it happens. So diffuse axonal injury is very, very dangerous, and this is the extreme degree of traumatic brain injury. So brain injury, we started with contusion. Coup contusion, at the site of impact you have contusion. Counter coup contusion, opposite to the site of impact you had counter coup contusion. Beyond that, you had necrosis, hemorrhage at the site of contusion, which can lead to further damage. And next is the classification of traumatic brain injury, which is done based on the Glasgow Coma scale, consciousness and presence of amnesia. So based on that, you have mild, moderate and severe. Mild is concussion, severe is diffuse axonal injury. So concussion, medico-legally it is very significant because they may be in their lucid interval and later on it get worsen and people may die and you will be called up for negligence case. Or sometimes the concussion may be mistaken for drunkenness. Diffuse axonal injury, it is commonly seen in the junction of white and grey matter, and organically, like physically, grossly you will not be seeing any injury, but when you look microscopically in the PM, when you take the axon and you look inside, like stain them and see, you will be able to see this retraction balls in the microscopy. And how this happens is that because of the shearing damage, this angular gliding motion, you will get the axilloma damage. Axilloma damage will result in potassium and sodium influx, which will finally disrupt the axonal function completely. So this is the traumatic brain injury. And next what we are going to see is brain hemorrhage. So we have seen scalp, then skull fracture, then brain injury, the tissue of the brain getting injured we have seen. Now what you are going to see is brain hemorrhage. So brain hemorrhage, you basically have these: epidural, subdural, subarachnoid and intracerebral hemorrhage. So first we are starting with epidural hemorrhage. So epidural hemorrhage is the hemorrhage seen between, here do you see this white layer, this is the dura, between dura and skull. So it is the outermost region between the dura and the skull, you are seeing this hemorrhage, and this is known as extradural hemorrhage. And this extradural hemorrhage, it is always due to trauma. Almost always 90% of the cases you get extradural hemorrhage because of trauma, and the vessel that leads to this hemorrhage is artery, that is your middle meningeal artery, and it is mostly seen over the temporoparietal region. Temporoparietal region is the most common place where you will be seeing this extradural hemorrhage. And the complication is that first thing you will be seeing is lucid interval. So you will miss the case. You will miss the case. And it will accumulate very, very rapidly. The blood will accumulate very rapidly, and this will start acting like a space occupying lesion. So it will cause edema, herniation and contusion. Everything will be caused by this. So it will start accumulating really, really fast, and it will become a very big lesion, and it will start compressing the brain. Because of that, you will be experiencing all the space occupying lesion symptoms. So this is very, very dangerous. This is very uncommon, but mostly when trauma happens, this will occur very acutely and it will cause this space occupying lesion like symptoms. And medical legal importance is that the same thing, all the head injury you will have these lucid interval period, and observation for 24 hours is important. And especially in this EDH and SDH, this lucid interval is very, very common. So this is the importance of extradural hemorrhage. So extradural hemorrhage, what you have to remember is where it is seen: outside the dura, beneath the skull, and it is arterial in origin, middle meningeal artery, mostly seen in the temporal and parietal region, and this occurs very acutely following a trauma, and it accumulates really fast and it compresses the brain tissue, leading to herniation and edema. So this is about epidural hematoma or hemorrhage. Next what you are going to see is subdural hemorrhage. So here this one, this is subdural hemorrhage. Here you see this is dura, right? So beneath the dura and above this layer known as arachnoid layer, you are seeing a hemorrhage. So this is your subdural hemorrhage. So it is seen beneath the dura but above the arachnoid membrane. So this is above the arachnoid membrane you will be seeing. This is subdural hemorrhage. So radiologically this will look like this. This will look like this. subdural hemorrhage, and this like this, it will look like extradural hemorrhage. So this is how radiologically it will look, and the vessel that leads to this subdural hemorrhage is venous. These are bridging veins from the sagittal sinus. So this is the common vessel that will lead to formation of the STH, and since it is a venous vessel, you get very slow accumulation. You can also get chronic and subacute STH, and this is commonly seen in extremes of ages. In old age people and young people, you will be seeing extreme of ages, you will be seeing this, and causes, it is trauma. Mostly it is trauma. Sometimes even a trivial trauma can lead to this. Like this is most commonly seen in drunkard people. So they will have these repeated falls, and this old person, they may fall in the bathroom or something, there will be very trivial fall, but because of the trivial fall, there will be slight damage to the bridging veins and blood will start to accumulate. And initially there will not be anything. There might have been a period of loss of consciousness, but there may not be anything also. So what will happen is that this blood, it will keep on accumulating, and after some time it will present as either a subacute or chronic STH, and you can see a mass growing, and because of that mass you will have infection or you will have this space occupying lesion like condition. Everything will be seen in this subdural hemorrhage, and it is most commonly seen with boxers, drunken people who keep on falling repeatedly, and old age people. And the medico-legal importance is the lucid interval, and when there is repeated trauma to head like boxers, you can get this subdural hemorrhage. When there is repeated minor trauma to the head or when there is a fall, you can get this subdural hemorrhage. So extradural, outside dura, subdural, beneath the dura. So we have done these two hemorrhages. Next is subarachnoid. So this is subarachnoid. Here you can see it is beneath the dura and beneath the arachnoid but above the brain tissue. So this subarachnoid. So grossly, this is your extradural hemorrhage. This is your subdural hemorrhage. Next, what we are going to see is this. Do you see? Here you can see hemorrhage, a diffuse hemorrhage over the brain in both of these. Now, SDH and SAH, both will be seen beneath the dura, right? Now, how will you differentiate SDH and SAH? The only definition is that SAH will be seen under arachnoid. It will be seen under arachnoid above the brain tissue. So this is how it will happen. But how will you differentiate an SDH and a SAH is that you will pour water. You will pour water, and if the hemorrhage clears, it is the case of SDH. If the hemorrhage stays, then it is a case of SAH. Clear? Why? Because this thin layer of arachnoid, it will prevent the hemorrhage from getting washed away by the water. So when you pour water over the brain, if it is a SDH, it will be above arachnoid, right? Dura we have already taken. So now what is the uppermost layer? It is the hemorrhage, and beneath that you have the arachnoid. So SDH above the arachnoid, it will wash away. SAH beneath the arachnoid. So arachnoid will prevent the water from washing away the hemorrhage. So this is how you clinically distinguish a SAH and a SDH. And this subarachnoid hemorrhage, mostly it is due to trauma and sometimes due to pathological reason like aneurysm rupture. If there is any aneurysm rupture, you can see this subarachnoid hemorrhage, and this subarachnoid hemorrhage always presents with this thunderclap headache. They will have very severe headache which will look like a thunderclap, like thunder had clapped their head, like that they will feel. So this is how subarachnoid hemorrhage happens. Next to that, what we have is intraparenchymal or intracerebral hemorrhage. So this is intracerebral or parenchymal hemorrhage. Here what happens is that mostly if there is any malignancy or hypertension, uncontrolled hypertension which will result in rupture of the blood vessels and bleeding. So all these mostly pathological condition, it will result in this parenchymal hemorrhage, and this has very poor prognosis. So basically you have EDH, that is extradural hemorrhage above the dura, SDH subdural hemorrhage beneath the dura, SAH subarachnoid hemorrhage, that is beneath the arachnoid membrane, and finally intraparenchymal, that is inside the parenchyma. Lucid interval you will be commonly encountered in EDH and SDH, and subarachnoid hemorrhage you can differentiate from the subdural hemorrhage by pouring water. If it washes away, it is subdural. If it does not wash away, it is subarachnoid. And this subarachnoid mostly due to trauma and sometimes due to pathological condition like aneurysmal rupture, it can happen. And finally, you have the parenchymal hemorrhage, which is mostly pathological. You have some malignancy, or you can have this hypertensive bleed which will lead to the parenchymal bleeding. So these are the important brain hemorrhages that we have to know. Now in all these brain injury, what will happen is that there are two things which is medico-legally significant. So first is this post-traumatic automatism, and next is this amnesia. So in cases like certain very severe head injury, what will happen is that they will be in this disoriented phase. The person will be disoriented and they will do some purposeless repetitive action towards stimuli. They will keep on doing some purposeless activity. If there is a stimuli, they will keep on doing some activity repeatedly without any purpose. So if they commit anything during this phase of automatism, they keep on repeatedly doing this activity, we call it as post-traumatic automatism. And if they commit any crime committed during this is they are considered not criminally responsible. So this is post-traumatic automatism. This is something medico-legally significant. Next is amnesia. So here what will happen is that following a head injury, there is a chance for amnesia. Like it may happen or may not happen, but what happens is that some people, they will experience amnesia and they will start making up for the blank memory. So they will make up some stories, they will start confabulating. So confabulation will happen and they will give you a lot of lies. They don't know that they are missing that part. They won't do it intentionally, but something organic disorder had happened. Because of that amnesia, they will start making up things just to fill that hole in their head. So this thing, when you are integrating them and they are giving complaint against some people, this can be confusing. If they do this in this amnesia phase, it can become very problematic to the people who are integrating. So these are the medico-legal significance of this brain injuries, post-traumatic automatism and amnesia. So with this, we are ending the brain injury. Next we will be seeing the spinal injury. Now we are going to see injuries to the spine. In the spinal injury, the first thing that we are going to see is railway spine. So railway spine is something that happens because of this sudden hyperextension and hyperflexion. So what will happen is that in case of railway spine, like in railway travel, because of the repeated movement, like in the old period when the railway is not that advanced, what happened was that there will be repeated jumping. So what they will do is there will be sudden extension, there will be sudden flexion, and it will keep on happening. And because of this repeated motion, repeated to and fro motion, what they had was they experienced like some numbness, back and neck pain, and they even had this tingling sensation. All these symptoms were experienced by the frequent travelers, and what they did was like it was very transient and it will happen for some time and it will go away for after some time, and they claimed compensation. So they claimed compensation. So what happened was that they tried to understand what exactly is the damage to the spinal cord. Why is this happening like that? They tried to understand, but there was nothing visible organically. So they simply said it is concussion of spine. So it is a concussion of spine which is leading to the symptoms. Like that they finally concluded, and nowadays this railway spine is not happening in the train travel. So this is also known as concussion of spine. Next is whiplash injury, and this is the most dangerous injury commonly seen in road traffic accident. Road traffic accident, this is where this sudden acceleration and deceleration happens. Because of that there will be hyperextension and hyperflexion, and this hyperextension, it is highly dangerous. So what will happen? This flexion, it will be prevented by the posterior neck muscles. So it will prevent that hyperflexion. But this extension, it will not be prevented by the anterior longitudinal ligament. Because of that, this extension will go to a lot of degree. So this hyperextension and hyperflexion, this keep on happening. So because of the sudden acceleration, this extension will keep on happening, and what will happen is that there will be severe injury to the spinal cord resulting in paralysis. So there will be paralysis, and lot of spinal symptoms keep on happening in this whiplash injury, and this is most commonly seen in the road traffic accident. Along with that, they also had dislocation of upper cervical spine and contusion and laceration of the spine if there is very severe damage. So basically in the road traffic accident, when there is this sudden deceleration, what will happen is that the neck will travel. So it will flex and it will extend, and because of this flexion and extension, sudden action, what will happen is this, the spinal cord, sometimes it will get completely severed or lacerated, or if does not get lacerated, it will become contused. Because of that, they experience lot of symptoms, and it is known as whiplash spine injury. So spine injury, you had railway injury and this whiplash spinal injury. Railway injury, railway travel, it used to be caused, and this whiplash injury, it is caused mostly in road traffic accidents. Next what we have is cardiac tamponade. So this is cardiovascular system. So here what will happen is that when there is a trauma, mostly some sort of penetrating trauma, like you had a rib fracture or stab wound, which goes and penetrates your pericardium. So there is penetration of pericardium. What will happen is that because of damage to vessel or damage to the heart itself, what will happen? There will be oozing out of blood, and all the blood, it will accumulate in the, there will be blood accumulation because of damage to heart or coronary arteries. So there will be accumulation of blood. So when the blood keep on accumulating, it will prevent the expansion of the heart. So the expansion of heart is prevented. Prevent expansion of heart, and because of that, the heart will go into cardiac arrest. So it will go into cardiac arrest. So that is what we call it as cardiac tamponade. So there will be some sort of injury. There will be a rib fracture or stab to the chest which will penetrate the pericardium, and it will go injure some vessel or the heart itself. Because of that, there will be oozing out of the blood. That blood, it will come and occupy the whole pericardium. So the pericardium will become very tighter and there won't be enough space for the expansion of the heart. Because of that, the heart will go into arrest. This is known as cardiac tamponade, and this is one of the important cause of sudden cardiac death. You will get sudden cardiac death, and this is how the blood clot will look like. So this is your pericardium. You could see all the fat in the pericardium, and this pericardium, when you open it up, you could see the blood clot, and beneath that you could see the heart. See, this is the heart. When you remove all the blood clots, you can see the heart. Sometimes you will be able to visualize the myocardial injury also. So this is cardiac tamponade, and this can happen because of blunt trauma causing rib fracture or stab wound resulting in penetrative injury. Next is Commotio Cordis. So in Commotio Cordis, what happens is that there will be a blunt trauma to chest. So to the chest there will be blunt trauma. Over the sternum there will be a blunt trauma, and all of the sudden, suddenly the patient will die. This is commonly seen in young athletes. So this is commonly seen in young athlete. They will be playing something. They will be playing football or something, rugby or something, and there will be sudden impact over the chest region, blunt trauma only. But what will happen? They will suddenly go into arrest and they will die. There will not be anything significant. You will not be able to find out any injury over the heart or the external region. But what happens is that this is more commonly seen among people with hypertrophic obstructive cardiomyopathy. So this is a predisposing condition. People suffering from this hypertrophic obstructive cardiomyopathy, they can get into this Commotio Cordis. This is known as Commotio Cordis, and the mechanism is that this sudden trauma, it will result in ventricular fibrillation. So this is the mechanism. Because of the sudden trauma, there will be change in the electrical activity which will result in ventricular fibrillation resulting in the death, and it is commonly seen in young athlete. Like they will give the history of he was playing very happily, all of a sudden something hit him and he just collapsed and we found him dead. Like that they will give the history. And if you find out further, you will get to know that they might be suffering from this HOCM. So this is HOCM is a very important predisposing factor. Sometimes you won't be able to see any predisposing condition, but still they will be suffering from this Commotio Cordis. So the mechanism of death here is due to ventricular fibrillation. So this is the spinal injury and the heart injury. So these are the regional injuries, and the most important thing here is the Coup and Contracoup contusion. It can be asked as a question, and the types of fractures and contusion of the brain tissue will also be asked, and diffuse axonal injury, it is an important thing. So next what we are going to see is traffic accident injuries. So first what we are going to see is automobile accident injuries. In this we will be seeing injuries to the occupants of vehicle, pedestrian injuries, and the medico-legal significance of this automobile accident. So mainly we will be seeing what are the injuries that can be commonly seen in this traffic accidents. So the first thing is this. So pedestrian injury. So in case of automobile accident, the first thing that we are going to see is pedestrian injury. So this pedestrian injury, it is basically divided into three types. First is primary impact, then you have secondary impact, and finally secondary injuries. So these are the three types of pedestrian injury that can happen. So what we mean by primary impact injury? So here, so the car is traveling in this direction and it is coming and hitting the pedestrian over here. So what will happen when the pedestrian is standing? or he is trying to cross, when he is getting hit on the side, okay, from the side it is hitting the pedestrian. So what will happen is that if it is an adult, this bumper, so this part of the car is known as the bumper. This is the part which will hit the pedestrian, and all the injuries caused by this bumper, we call it as bumper injuries. So this bumper injury usually result in fracture of bone where it is hitting. Especially if it is an adult, it will hit over the tibia. You will get tibia fracture which will be wedge shaped. So this bumper fracture, it is also known as wedge shaped tibia fracture, and it is seen in adults when the bumper comes and hit them when they are trying to cross the road. So this is the primary impact. This is the first point of contact. So an adult, he is trying to cross and a car is coming and hitting him. So point of contact will be the bumper and against the leg of that pedestrian. And the leg, you will get tibia fracture. Along with that, you can also get any abrasion and laceration. So these also will be considered primary impact injury. Most commonly, you will be seeing the wedge-shaped tibial fracture. If it is a children, the height will be less, right? So because of that, you will be seeing femur fracture. You will see femur fracture because of less height. So pedestrian injury, first is your primary impact injury. You have primary impact injury, and if the person is walking across and the car is coming and hitting him, he will get injury over the tibia. If it is a child, it will get injury over the femur, and the bumper will be the part which will be hitting them, and because of that they will be getting abrasion and laceration also. So this is primary impact injury. Now looking at this injury, we can identify the relative position of the victim and the car. How we can say is that if the car slowed down, like the driver will understand that they are going to hit that pedestrian, so they will push the brake. So because of that brake, the car will slow down and dip down. So it will dip down, and because of that you can see lower region getting bumper injuries. And you can identify whether, like, if that left side is getting fractured, then you can say that patient was going towards this direction. So if this is the car and it is coming in the direction and the patient is going this direction, and then his left side would be hit. And if he is coming in this direction, then his right side would be hit. So you can identify which is the position of the car and which is the position of the victim. You will be able to identify like that. So this is the primary impact injury. Next, what we have is secondary impact injury. So when they are, like, once the hit is done, when they got hit, what will happen? Like, they will lose their balance. They will lose balance and they will fall over vehicle. They will fall over the vehicle. So what will happen here is that they will lose balance and they will fall over the vehicle. So this is, there is again impact, right? They will impact over the vehicle again. This time they will get one injury, and those injury we call it as secondary impact injury. So first point of contact against the bumper, you will get fracture, that is known as primary impact. Second impact will happen when they lose the balance after getting hit and they'll impact over the car again. So this is your secondary impact injury. Primary impact injury, again they are getting impacted by the car, so this is secondary impact injury. So this secondary impact injury, mostly you can see it is seen over this thigh region. So they will be getting upper thigh pocket where you will have lot of hematoma and laceration. So this is one scenario, and they can also hit their head and they can get spinal and head injury. So this is one type of secondary impact. This happens when they lose the balance and they topple over the car. So this is one type of secondary impact. So next type is that what will happen, they will get scooped away. So they will get scooped away. What will happen? They will completely lose the balance, and the car, if it is going really fast, it will scoop them, it will take them and it will put them over and above the car. So they will go over and above the car. So they will be scooped up. They will be scooped by the car. This is second scenario. In this, they mostly get injury over the, they will mostly get injury over the neck and head and sometimes over the shoulder and upper back region. So this is second type of secondary impact. If they simply fall over the vehicle, they will get injury over the head, thigh and all. If they get scooped up and they go and hit the roof of the car, they will get the neck and head shoulder injury. And there is one more scenario. There what will happen is that they will be thrown away. They will be thrown far away, and vehicle that comes behind, that is coming behind, will run over. So it will run over them. So they will be getting thrown and they will cross this first vehicle. That is the vehicle that hit them. And they will be thrown over this and they will go hit the ground. Another second vehicle will run over them. The second vehicle will come and run over them. So there you will get complete avulsion, all sort of blunt trauma injuries you will be seeing in that case. So they will be simply falling over the hood, or they will be scooped up and they will be falling over the roof, or they will be completely thrown away and they will be ran over by another vehicle. All these consist of secondary impact injury. So this is your secondary impact injury. Now comes the secondary injury. So this known as secondary injury. Here what happens is that they may fall over the vehicle and get thrown away, or they may directly, after the primary impact, they will directly hit the ground. So when they hit the ground, when they hit the ground after impact on the vehicle, the injuries that they sustain, it is known as secondary injury, and most commonly it is most commonly they will get craniocerebral injury. So secondary impact when they fall over the car again, secondary impact when they fall to the ground, primary impact, first impact, secondary impact they fall over the car again and getting impacted, secondary injury they fall to the ground and they get craniocerebral injury. So these are the three types of injury that you can expect to see in a pedestrian. Now there is something known as Waddell's triad. So Waddell's triad, like this triad consists of these three: primary impact, which will lead to tibial fracture, secondary impact, which leads to pelvis fracture, and secondary injury which results in craniocerebral damage. This consists of the Waddell's triad, and in run over injuries you mostly get this grazed abrasion, and complete avulsion. There will be complete crushing. They will be avulsed and there will be eggshelling of skull, then multiple fractures of the rib and all the abdominal organs. It will be crushed and pulverized, that they will go into pieces, they will become very mashed together. So, all these are seen in this run over injuries. There is something known as rollover injuries. So, in this rollover injuries, what will happen is that if the chassis of the car is low, what will happen? Like this is the chassis of the car. So, this is the chassis. So, if it is really low, what will happen is that car will push them and roll over the victim. So, it will simply push them, it will roll them over in the ground. In this case, there will be a lot of grazed abrasion. They will get lot of grazed abrasion and head injury. So, this is rollover. This rollover is different from run over. Run over, they will go under the vehicle. Rollover, they will be simply rolled like a dice. The car will just roll them over like a dice. So, these are the injuries that you can commonly expect to see in the pedestrians. You have primary impact, secondary injuries, then you have rollover injury and run over injury. So, these are the things, and Baddel's triad you have to know. So, this is about pedestrians. Now, we are going to see the occupants of the vehicle. So, when the occupants of the vehicle, if it is a non-ejection injury, if they are wearing the seat belt, what will happen is that this secondary accident will happen. So, they will be, because of the sudden deceleration, they will, especially the driver, they will hit the steering and they can like hit the windshield if they don't wear the seat belt. Seat belt absent, they can go and hit the windshield and they may be even thrown over. So, these injury, it can happen because of the hit in the steering. They can get sternum fracture and they can also get rib fracture. So, this is common in the driver. And next is airbag injury. Because of the airbag, there is multiple rib fracture and they can also get hemothorax and hemopericardia. Because of the sudden deceleration, this airbag, it will press over the rib and it may cause rib fracture leading to hemothorax and hemopericardium. And next, what will happen is that we have something known as deceleration injury. Because of the sudden deceleration, you will get to see certain important injury. One is aorta. So, in aorta, you will get to see ladder tears. So, this is the intima of the aorta. So, this is your aorta and intima, you can see this horizontal shaped tears. So, this is known as ladder tears of aorta and this commonly seen in the isthmus of aorta, because this is where it gets compressed between the sternum and the vertebra. So, this position, it is relatively fixed. Because of that, it will get compressed between the sternum and the vertebra and there will be tear in the intima of the aorta. So, this is the most common deceleration injury that you can experience. Apart from that, you can also see compression of the knee and they may compression of the knee, like the knee will go and hit against dashboard. So this can also happen. So this will lead to fracture of the knee bone patella. This can also happen. And next you can see chance fracture. This is fracture of lumbar vertebra. This is fracture of lumbar vertebra. And these are the things that you can commonly see in this car occupants, like occupants of the vehicle. And this seatbelt injury, and the triad we call it as this aorta injury, then laceration of mesentery, and the fracture of vertebra. So these are known as triad. These three are most commonly seen. Because of this, you will be seeing the laceration of the mesentery, like how aorta is getting compressed, the mesentery will also be lacerated, and you can also see lumbar vertebra getting fractured. So these are the common thing that you can see in occupants of the vehicle. Sometimes what will happen is that they will be ejected out. They will be completely ejected out, and they will go hit ground. And all the windshield glasses, it will cause puncture laceration. So these are also common in the occupants of the vehicle if they are not wearing seat belt or if they got ejected. This is very common. And underrunning is when the car goes under a larger vehicle. When the car goes under a larger vehicle, like everything will be compressed. There will be compression of the car and occupants. So everything will be completely avulsed and everything will be pulverized. So these are the occupants injury that is commonly expected in a road traffic accident. So pedestrian, you had primary impact, secondary impact and secondary injury. Occupant, you mainly had this aortal injury, tear of mesentery and vertebral fracture, especially the lumbar vertebra. And you can also have this sternum fracture, rib fracture, patella fracture, hemothorax and hemopericardium. And the medico-legal important aspect of this accident is that, like most of the cases, if there is any suspicious death or homicide, can be masked with accidents. Like they will kill somebody and they will throw in the highway. So the vehicle, it will come and run over the body and it may look like an accident. So you have to completely, thoroughly examine all the injuries. So thorough examination of all injuries is important. Like you are seeing a sharp force trauma in this case means you have to suspect something. So you have to correlate the injury and the history. If you are suspecting something, like you are seeing a ligature mark around the neck in a road traffic accident means you have to definitely think of something like strangulation or something would have happened like that. You have to have the suspicion. So this is the medico-legal importance of accident. Sometimes homicide will be masked by looking like a accidental death. So this is the medico-legal importance of this accident, and this is a very, very important practical aspect. So with this, we are concluding this chapter of regional injuries, and thank you for watching.